David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist, and welcome to Two Shrinks and a Mic, our newest episode.
We're going to continue today with the discussion we had on the previous episode because of how important it is. I've been amazed when I talk to individuals in the lay public about the various disciplines within mental health care, whether it be psychologists, psychiatrists, mental health counselors, marriage and family therapy. People don't know the difference between these different disciplines. People will look at me at times when I meet them for care, and they'll say, "Oh, you are a medical doctor." But this other person I saw who's a psychologist is also a doctor. So how are you all different? It's just really incredible how people don't understand that. So part of what we'd like to do today is talk about the differences in the various disciplines, but also talk about how to choose a particular discipline in mental health to get care. I'll start talking about psychiatry because it's dear and close to my heart. I decided to become a psychiatrist in medical school, although I was open-minded about each different discipline I went through: pediatrics, surgery, internal medicine, neurology. But at the end of the day, I enjoyed the challenge of the brain, but also I enjoyed talking to people. And psychiatry was an area that allowed me to do both, to pay attention to my interest in neuroscience and the brain, and as well as my interest in people's lives and what their experiences were like. But psychiatrists go to medical school, and we go through the full training in medical school and come out with the same knowledge base that individuals who become internists or surgeons or endocrinologists, et cetera, become. But then after that, we go to psychiatric residency, which is another 3 or 4 years of training in which we focus in on topics in psychiatry that will include a big focus on the brain and how the brain can lead to changes in personality and emotional state. Big focus on medication and what we call psychopharmacology, and the disease processes that are in the DSM-5 manual, which is the Diagnostic and Statistical Manual in psychiatry and psychology and in all the fields that's put together by the American Psychiatric Association. We have a lot of clinical training and a lot of textbook training. And when we're done, we think we know everything, but I can assure you we don't. And like I mentioned in the previous episode, it took me at least 5 years being out in the real world. And fortunately, I was in an environment where I had social workers and psychologists and other master's level mental health professionals around me in a setting where I also ended up going to the major wards in the general hospital. So I continued to interact with internists and surgeons and specialists. So it really allowed me over the first 5 years after training to broaden my understanding and recognize that I may have had a lot of book learning, but I didn't have a lot of real world learning in the field of psychiatry. And eventually I felt more comfortable in the knowledge base that I had gathered over time.
So that covers, in a very basic way, how to become a psychiatrist and things you go through and learn. To become a psychologist is a bit different. What it involved for me was 4 years of college specializing. I was pre-med, and when I was finishing up, I decided that I really wanted to get right into the understanding of people and what makes people tick. I was perplexed by some of the things that I would see in people and why people would do what they would do. And I said, this is much more interesting to me than if I had studied, anatomy and just, stayed with the physical side of things. So with that in mind, I was able to get into a doctoral program, a clinical psych program, which involved 4 years or 4.5 years of coursework and clinical experience and practicums ranging from clinics to psychiatric hospitals. And 90% of the clinical coursework is trying to understand human behavior, some of it normal behavior and some of it abnormal behavior, pathological, and the different psychiatric diagnoses. From there, the average person who gets their degree as a PhD or a PsyD psychologist, which I'll talk a little bit about. Um, After that, there's a certain amount of time that you have to put in hours of training in order to be licensed. For me, at the time that I was going through all of this, I decided I really knew so little that I decided to go on for another, what turned out to be 6 years of training in psychotherapy and psychoanalysis. So, in all, it was a long haul, but it was really so worthwhile. And in my case, and in most clinical psychologists, they go into some sort of either hospital setting, clinic setting, or private practice. Um, I have a PhD, which was the only way to get a doctoral degree for many, many years. And a PhD requires that you also do a research dissertation, which takes quite some time. The PsyD became a program that was for people who didn't really want to spend a lot of time dealing with and understanding how to do research. And what they did was create a different degree, a PsyD, which was all of those years were just clinically based and did not involve research. So that's a psychologist. Psychologist doesn't deal with the medical aspect and doesn't prescribe. They have to understand the basics of psychopharmacology and what's out there and what's prescribed for the different disorders and the interaction between biology and psychology. But it's basically looking at the problems that people have from this side of the room, and the psychiatrist looks at it from the other side of the room, and trying to put that picture together.
You know, the difference between the disciplines some becomes a bit of a turf battle. I remember in the early days of my practice, I'd hear from psychologists and other therapists who had referred me a patient for evaluation, mainly to determine if they needed to be on a medication. And I would then send the patient back to them for therapy while taking care of the medication. And the comment I'd get from them was, wow, you sent the patient back to me. And in the early days, maybe a couple of decades ago, that was a real problem because the psychiatrists, although we were trained in psychotherapy and it was part of our training, we certainly didn't have the intensity of psychotherapy training that a doctoral student would have or a master's in mental health would have. And there was a tendency just to take over the case and provide the talking therapy as well, which sometimes worked, but a lot of the times it was really not appropriate. And so I guess I thought differently, and I felt it was quite reasonable to work with a therapist in a team model, as long as you can communicate. And I think that's one of the reasons why we've worked together for so many decades at this point, because of the fact that we recognize that each of us have our own area of expertise, and we've never really gotten into turf battles. But that unfortunately has been an issue in the last 10 years or so. Individuals trying to become prescribers when they really weren't trained to do that. And now if you go to many urgent care centers or mental health centers, you'll be seen by a nurse practitioner or a PA, a physician assistant, which can provide good care as long as it's supervised by the MD or the PhD. But there is more confusion, I think, within the field now than ever before. Part of it's because of lack of adequate numbers of clinicians. And so the nurse practitioners have ended up being a major source of psychiatric, quote unquote, care in substance abuse treatment centers or urgent care centers. And that at times is an issue. But the notion of what professional to see becomes a bit confusing. How do you differentiate between a master's level mental health professional and a doctoral level mental health professional? I imagine if we asked the person in the street, they wouldn't know the difference. But you're very much aware of the difference
Yes.
between your training and that of a master's level person. So it's always tough. But at the end of the day, you need to decide for yourself if the person you sat down with really became your advocate. Do they really give you a sense that they're there to take care of you, to not just in an abstract fashion deal with symptoms, but to take care of you as a whole person, whether it's the psychological issues you're having, or the family issues, or the job issues, et cetera, which at the end of the day, like I said before, how good a listener were they? How much did they pay attention to what you had to say? So at the end, so once you're finished with the evaluation, think to yourself about, is this person going to be there for me as we move forward?
Yeah, there's that part of it, and then finding somebody who really knows their stuff about whatever it is that you need help with. You are able to find a master's level person who really, really knows their stuff much more than maybe somebody with a doctoral degree if they've gone for all kinds of training and they have a lot of experience in treating that. I know some master's level people who are brilliant at treating OCD. And I know other doctoral level people who are not brilliant. They really know very little about treating OCD, but they treat it. So it's the degree is a piece of it, but really it's finding the person who really knows their stuff about this problem. And and this is the hard part to evaluate, which is what you're talking about, really cares about treating this, even enjoys treating it because they like to see people get better. And I've always said one of the reasons I love to treat anxiety disorders is because I see people get better. But I know spending a lot of years doing it, how to do it.
We talked about this before, but if you go see a hormone doctor, endocrinologist, and let's say you interviewed 4 different endocrinologists because your general physician told you that you had a sluggish thyroid and you wanted to get treatment from a specialist, you can be pretty certain that their training has been all similar. There's not going to be a big difference between the scientific base and type of training that endocrinologists would have. And that's true for most specialties in medicine. But mental health's a whole different animal. And the training can be varied. I mean, way back in the 1960s and 70s and 80s, if you looked at the mental health care and therapy care, there'd be various schools. There'd be the Jungian school, the Karen Horney school, Aaron Beck school, and people rigidly would stick with the particular discipline they had been trained in without recognizing that we need to change as new advances are made and we learn more about it. So see that in psychiatry. I see, individuals who have a tendency to have gotten so interested in the concept of bipolar disorder that everybody that comes into their office with a complaint of depression get diagnosed as being bipolar and get the same medication regime that they give to everybody, or the psychiatrist who has their favorite antidepressant and has not considered the possible need for different types of antidepressants for different types of depression. So recognize that there is that kind of rigidity that exists within mental health. The case in point, I saw a woman the other day who has a significant trauma background and numerous episodes of psychological trauma in her life, and had been seeing a therapist. And I asked, what's the therapy all about? What happens in therapy? And proceeded to tell me that basically talk about the week and what's going on in life. And I said, well, has there been any talk about the need to focus on specific trauma therapy involving something like EMDR, other types of trauma-focused therapy? And so part of the problem is at times not really focusing on the core problem, but instead going into a generic direction in psychotherapy.
Yeah, I mean, it's true. A lot of times we do talk in a general way with people about how their week was or about how things are in general. But it still has to coalesce around a particular issue or symptom or methodology that targets what we're trying to help the person with. I was blessed with learning a quote when I was in training, and I didn't know how important it was at the time, but the quote was, know all theories, love a few, and wed none. And I think that's really helped us both as we've gone through our careers. So it's helped us evolve and not become rigid and not become so in love with a particular method that patients and their problems have to fit into our perspective Rather, we've learned that we have to, it's a combination of fitting into the person and the person fitting into the treatment. So that's really important for people to know. There's different treatments out there, and there's not one, and there's not one for all. It's not a one size fits all kind of model. So again, you do whatever research you can do to decide, okay, based on what I know of my problem, where would be the best place to go and what kinds of treatments. So we have the psychopharmacology model, and outside of that, we have probably the most common and popular model now in terms of non-medical treatments would be the cognitive behavior therapy for one, and there are others that go with it, but really that's a big central form of treatment. There's different variations of it that are applied to the different diagnoses.
We've talked all along about what it's like to experience problems with anxiety or depression, and what's common in all of these states is when you get into that kind of severe emotional distress, you feel like you're stuck, you're trapped. It's almost like being in a paper bag and not being able to box your way out of it. And that's frightening because people who are in that state think it's never going to change. They'll be this way the rest of their life. And they begin to get hopeless and feel helpless. Um, and it's really dramatic when people begin to feel better and they can realize that there's light at the end of the tunnel and they're not stuck. And that's one of the gifts of successful treatment. Um, but the hopelessness is a real problem, and has to be addressed early on. And that's where the clinician can be helpful because individuals need to hear that you can't get better, and that this is not going to be the state that you're in forever, and that you can get out of this state with some help. And I tell people that I'm willing to come up with the best medication I can, but from your end of the deal is to get out and exercise and walk, to not get stuck in your apartment all day long because it's going to make the worrying worse. Because the more you stay isolated, the more you feel hopeless and stuck and immobilized. Um, and it's really critical to have that kind of agreement that I'll work real hard to help you, but I need you to try to help yourself.
There may be in the time that we do have left today, we can talk a little bit more specifically about the types of things that you offer to patients in terms of medicines for in general, not necessarily related to a particular type of problem, but just, what if somebody comes to you, what they might be looking at in terms of treatment. And maybe I can spend a few minutes talking a little bit about what cognitive behavior therapy is like so people know what to expect that way.
Sure. I think the first step is to help people understand that there may be a biological imbalance that's part of the disorder going on. So let's say, you lost your job, got rejected by a boyfriend or girlfriend, went through a major life crisis, and you ended up being anxious and depressed. Um, I'll tell people that this may be a temporary state of your emotional nervous system. Medications can help, uh, but in addition to medication, working with somebody psychologically in psychotherapy is just as important. I can't tell you how many times I'll see somebody who wants a quick fix and a magic bullet pill, and has had no talking therapy,
Mhm.
and that's been missing. And I'll tell them I'm happy to go the direction of the medication, but there isn't any silver bullet. Sure, the medication can help decrease the tendency to be stuck in your head and obsessing and having reverberating loops of brain where you're like a broken record and you can't turn your brain off. But at the same time, you have to be able to deal with the marital problem you have, or the lack of a good match in the job that you have, or the self-negative thinking you've had all your life that came out of a problematic family of origin. We can't ignore that aspects of it. But in general, the medications that I'll choose would either be medications to address depression, and at some point we'll talk more in detail about that. Interestingly, the most common medications we use for depression now are the selective serotonin reuptake inhibitors. Back in the day, in the 1950s, 60s, and 70s, the tricyclic antidepressants were the drugs that we had, but they had lots of side effects, and that made it tough to prescribe medication because people had to put up with a dry mouth and constipation and sedation and difficulty with erections, etc. Um, but the new medicines are very effective. But interestingly, the antidepressants are also very potent anti-anxiety agents, and they're not anti-anxiety because they're sedating, like a tranquilizer like Xanax would be, but they're anti-anxiety and being anti-obsessive. They decrease the brain noise, the static in the head where you can't turn your brain off, and for most depressions, I see that as a big part of it. So the antidepressants are very valuable for both depression as well as some anxiety states. Um, when there's a disorder involving disordered reality testing and delusions, hallucinations, which are auditory or sensory experiences or visual experiences that shouldn't be there, antipsychotic medications are utilized for that. Um, the anti-anxiety agents, which primarily are the benzodiazepines, Xanax, Valium, Ativan, Klonopin, are the best examples of that, are helpful. The problem with those is that they lead to tolerance and dependence over time. And if you've been on it for months and months and months or even years, it can become very difficult to get off of them. Um, but again, I can't emphasize how important working with a team and determining whether or not psychotherapy is part of the process.
Here's a great example of the effectiveness, though, of medication. This is just one example of it. This is a young woman who has obsessive compulsive disorder and social anxiety. And when I met with her initially, she had been on an antidepressant prescribed by her family physician who lived in another city and was getting marginal help from it. But her overthinking and obsessing was just really severe. And it would basically involve overthinking that people, her friends or other people, didn't like her really, or they were judging her, or they really weren't as caring as she wanted them to be. And so, but she would never really have a quiet moment about any of this. And so it was clear that she needed some cognitive behavior therapy to help her begin to look at her thinking and her beliefs and the inaccuracies of them and start to challenge the way she thought and replaced a lot of this thinking with actually more objective, logical thinking so that she wasn't automatically seeing everything as bad. But it was really not making any difference. I mean, she understood the process and she understood what we were trying to do, but she could not really quiet down that overthinking, obsessive quality of her brain. And I ended up speaking with her doctor up north, and we decided to increase the dosage of the medicine. And within a few weeks, she started to significant improvement. And what that did is it obviously made her feel a lot better for a while, but it enabled her to use the techniques in a more efficacious way. She couldn't before, and now she could sort of like get her arms around it and start to apply some of these cognitive behavioral techniques. And that really helped for a while. But as you know, you this better than me, you would see at some point you may even still need to increase the dosage to get a better response, which we did, and then she made even more improvement, and then she really turned things around. I don't think she would have turned things around at all had it not been for the role that the medicine played in her being able to change a lot of her thinking. So what's out there in the real world, though, is you could end up being that patient who goes and sees the person who just does, sees somebody who just does cognitive therapy, and over a period of time get like tired of it and feel hopeless from it and quit. Or you could see somebody who just gave you the medicine, and if you don't know how to change your thinking, the medicine will help to some degree, but may not do the job that we need it to do in the long run. So that synchronicity of the medication and the cognitive therapy is so, so important.
Well, that's what I tell people all the time when, especially when they have an anxiety disorder that they come in with. I'll say that the medication is going to help, but I view the medicine as building a foundation upon which you can more effectively do the therapy work that you need to do. There is the rare individual who will have a dramatic response to these medications and become symptom-free. But for the most part, it's the medication is really critical for starting the process of the appropriate psychotherapy. And everybody wants a quick fix, and half of our challenge to individuals is to help them understand that it's a process, that it takes some time, but they will get there, and not to give up hope, and to view the possibility of success and the possibility of things improving in the future. And so on that note, these two shrinks would like to wish everybody a happy holiday and a happy new year, and
Very much so.
wish you a good 2026.
And we'll see you, I guess, next year.
Hard to believe.
So from Two Shrinks and a Mic, we'll see you soon. The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.